It is my privilege and honor to introduce our next panel. One of the things Bridget talked about was the torrent of data that is available. And to apply artificial intelligence, and ChatGPT, and all these wonderful technologies, we have to have data to do that. And we have to have it in a way that we can actually personalize it to help us and our families live better lives. So I'm excited to invite the panelists to come up. Sara Vaezy is our moderator, and she is the Executive Vice President and of Strategy and Chief Digital Innovation Officer. Under her responsibility, she manages a $300 million investment fund. So if you ever think that your healthcare provider isn't committed to the people in this room, to innovation, to entrepreneurs, again, please doubt it no more. Take it away, folks.
Great to be here with all of you. Dwight, thank you so much for the introduction. And Bridget, what a wonderful opening. Thank you so much. I loved your data points. You know, we're generating 50,000 gigabytes of data every second. Did I get that right? Amazing, and 97% of it is unused. And for those of us that are working in the provider systems and have electronic medical records, we know that much of that data, for instance, exists in unstructured notes, about 80% of it, and it's very underutilized in terms of its benefits. So I'm really looking forward to our conversation today, and of course, as Dwight opened it up, we're going to be talking about data. And I am joined here by two amazing co-panelists, and I will hand it over to Dr. Guller first to have her introduce herself.
Thank you, Sarah. Good afternoon, everybody. I'm Tarannum Guller. I'm the Chief Medical Officer at Regional Medical Center in San Jose. We're one of two facilities here from HCA Healthcare in Northern California. HCA Healthcare is one of the largest healthcare entities in the country. By way of background, I'm internal medicine trained, have moved here from the East Coast. I trained there at Mass General and Newton Wesley. Moved here to be with my husband, who was at the time doing his business degree. So I landed up at UCSF and then never left. So I've raised 3 kids here in the Bay Area, one of whom has recently graduated and is majored in economics and data science. My husband is an expert in AI and ML. So you can imagine the conversations at our dinner table are very data-driven. And of course, healthcare has to chime in once in a while, so here I am. And to Peter.
Thank you.
Hi, I'm Peter Fitzgerald. It's a pleasure to be surrounded by younger, smarter people. So we'll start with that. I am an engineer by background. As I was getting my PhD, started a first healthcare company. I didn't really know what I was doing because I was an engineer, and so I didn't really understand healthcare. So when we transitioned that, Hewlett-Packard paid for me to go to Boston for medical school and learn something, and then came back and trained at UCSF, and then I've been a professor at Stanford for the last 21 years. You know, in this Bay Area, like everybody, you meet smart people, young entrepreneurs, and you get involved in these startup companies. I'm an interventional cardiologist, so if you have a heart attack, I unplug your arteries. If your valves don't work, we fix those. But you see needs within a hospital. And then surrounding by folks that are good business, intellectual property folks, you get in that starting companies. And there were 25 plus companies. Probably the thing that I learned the most was I failed 5 times, 6 times. And that is what I teach at the business school is mistakes. Because there's a lot of young folks, especially as we begin to talk about data, that haven't fallen into the same potholes I have. And I've inscribed my name in a lot of those potholes. So I get the opportunity to now transition to my 3rd career, and I'm a venture guy. I have offices in Tel Aviv and in Palo Alto, and it's really a blast to focus on data-rich ways that we can improve, like Bridget said, the healthcare continuum that we are absolutely terrible at. And we'll get into a little bit more of those specifics. Not to be too negative, but I don't want to be too positive here because we've got a challenge that's the size of Everest to get over in our healthcare efficiencies.
Wonderful. Thank you both. I'm really excited about our conversation today. If our prep call was any indication, we're going to have some fun. So really looking forward to it. And I'm sitting here with two clinicians, so I'm not going to embarrass myself too much by talking about clinical data, but I do run the consumer-facing front end for Providence, so I have a couple things to say about consumer experiences. So anyway, we'll get right into it. What is it, let's just start with level setting. What does it mean to you when we say big things like data has the power to transform healthcare? Bridget talked a little about it. It can be assistive, it can be create a more accessible system, it can create a more affordable system. But what does that mean to you? And specifically, let's start with what kind of data are you thinking about or talking about? And is it all clinical? Dr. Guller, let's start with you.
Sure. Thank you for that, Sarah. And when it comes to healthcare, that's one field I feel that everybody is an expert in. You don't necessarily have to be a provider to be an expert in that field. By way of being a patient, by way of being a family member, by way of being a patient advocate, every one of us gains a lot of knowledge in that perspective. And I think that's where data sits today, is where does data drive the outcomes? Like Bridget was mentioning, what she alluded to was really the quadruple aim of healthcare, is how do we provide patient satisfaction, great outcomes, cost-effective care, and at the same time provide for a great experience for the care provider as well. So patient and physician satisfaction matters, and that's where the data intersect comes in my mind.
And is that all clinical?
Well, it could be clinical, yeah, or non-clinical, right? So clinical is just pure data coming from your patient on their own personal medical history, their family history, all of that. However, the non-clinical is just as equally important, and sometimes I see it as a tremendous opportunity where we can expedite care. So talk about deductibles, your health insurance, what's covered, what's not covered, what's authorized, what's preventing you from seeing your physician or seeking the right care at the right time. So all of that is a part of your clinical care, even though it's not directly clinical.
That's wonderful. Peter, over to you.
So I'm not that enthusiastic about the fact that we can just lump data, care, and continuum of that process in one sentence. We spend $4 trillion in this country on data, and our curve is way to the right than all the other people. And congratulations, we're number one on maternal mortality. 4 out of 5 hypertensive patients in my sport are uncontrolled. That's 93 million people. So with all this data, how are we going to bend that curve? Are we going to let the government come up with more acronyms? Remember, the government comes up with 3, 4, or 5 acronyms, and they really confuse people. And the only way we're going to actually utilize the data in a smart way, remember 36% of all the world's data is in healthcare. It's disseminated, it's disorganized, it's in silos, and it's unstructured. Do you think the government is going to be able to provide something that the docs can actually use, the payers can appreciate, the physicians can get behind, the patients can basically consume this? This is hard, and with most institutions, medical centers, in the red, that's not a great prodrome for, again, the data, care efficiency, and better care. So I think we need help from outside. There's other verticals that know how to do this. When you're in a house that's burning, you don't solve it from inside, you solve it from outside. So Oracle, Amazon, CVS, Walgreens Boots, the number of folks, Salesforce that announced yesterday, the number of folks that are coming in today, for me, is a bright light, but we're not going to solve it inside. So I think it's really important to call a spade, because we're going to get to that $9 trillion if we don't really pay attention and do something different. And we in healthcare need to wake up and do something different, especially with a forcing function that we just lived through globally, allowing us to appreciate care at home, allowing us to disseminate telehealth down pathways of different chronic diseases. Mental health, the ability to really reach out to those that have anxiety all the way to suicide. So for me, making these grandiose sentences don't make sense unless we put specific issues behind it. And again, it's not going to come from our government. It's not going to come from the medical centers. It's going to come from outside. Okay, how's that?
I think that was provocative enough. But I love the example, and the outside-in kind of perspective. I'll give one example of something we're doing very much aligned with that at Providence, which is that, and yes, we're on the inside, but we're bringing expertise from the outside. So today, we can actually look on our digital properties and understand, based on what people are searching for on our website, for instance, whether they might be, quote, in the market for something. So if someone keeps searching back pain and physical therapy on our websites, we can have a pretty good idea about what their needs are clinically, but that's not clinical data. And then we've brought in marketing expertise to basically say, okay, then how do you, in a targeted fashion, reach out to that person? At an N of 1 level, not at a sort of go by a billboard or a bus ad on the highway somewhere that says, we have orthopedic surgeons or, back surgeons. So I think your example is a great one. And I want to push on that a little bit more. One of the things that we talked about, and Bridget referenced it as well, is that the world is changing quite a bit. And one of the big themes that we're seeing is this notion of decentralization and new market forces that are out there that are contributing. They're either generating data themselves, or they're creating data moats, or they may be fragmenting care delivery in some ways. Just this general notion of decentralization. And I know one of the later panels is also going to be focused on edge computing, which is yet another form of decentralization. So what are the consequences of that? How does that impact what you're talking about, Peter? And is it overcomable? Is it going to require something new that we haven't implemented yet? How do you think about that?
I think that, and I don't know, to be honest, but I get the luxury of seeing 700, companies a year in Israel, as well as the Bay Area, in Boston, Minnesota, and now, believe it or not, Miami. And so I get to learn from these smart folks that are at generations, younger than I am. And there are some really unique ideas. For example, we have built all our data in silos, and nobody shares. Now, I know you do a great job at Providence, but that's, I'm going to wait for Kaiser and Gilsing. We'll see how that transition goes, because you're going to maybe teach them something. Geisinger is a great hospital, a great number of hospitals, but Kaiser really does a great job on community care. But, most don't. And when you see these youngsters saying, okay, you're in silos, and you don't share your data, we have different ways. It might be edge computing, federated learning, so that you coalesce just the envelope data, the insights, which is really important. Or we might have what's called, last one type of algorithms that are able to learn from these silos, but apply them to less robust data sets and actually come up with, inferences. So there's lots of ways I think we can learn from the outside in these startup companies, especially the ones that are really data-driven and have learned that in other verticals. The swarm of folks that are coming into healthcare today, it's just amazing. So conferences like this are perfect because you've got the eclectic people under a roof, listening to problems that they have either solved or they've understood with these technologies how to solve them. And I don't think just throwing up GPT, I call it generalized paranoia trend. And I don't want to tell you what DALL-E E2 stands for, because it's not that clean. But we can't just say that's going to solve the issue. We have to get to the fundamental. And the fundamental is, at least in my sport, the following. If you come in with chest pain, I know what to do with your heart attack, but I don't remember your name 3 days later. There is a discontinuity of care, and we don't have nurses. 250,000 have left this year, and they're projected to have more. So we need to bring in less skilled folks, fortified by data, so that those continuums for the great care that Dr. Guller does, she's going to not have to be the one that provides this continuum for diabetics, for chronic neurologic diseases. We're going to embrace non-healthcare professionals, but embraced with data to solve this problem, or at least encroach on it, because we're not going to solve it by just saying we have data. Agree or not?
I do. I completely. No. Where we are seeing the huge gap in healthcare really in the coming years, and even now, more so right after the pandemic, where you're alluding to people leaving the community, not just nurses, right? Physicians that were going to retire a couple of years down have decided they just don't want to do this. Life perspectives. COVID gave people life perspective. And so we're faced with how are we going to do more with less at a lower cost with higher quality. And how do you solve that outside of looking outside your house while you're also building your home from within? So when you talk about how are we looking at data trends within the four walls of a hospital, so you've got the healthcare team and you've got the patient. For the longest time, patients haven't owned the data, right? We have tons of data. But like Bridget said before, be it regulatory, be it compliance, be it medical legal, for whatever reason, the patient data isn't owned by patients. Anywhere else outside of healthcare, let's talk about consumers and sellers, for example. Who owns your data? Who's tracking your data? Who's making the decisions? So I'll give you a simple example. Think about Amazon. When I look to buy something on Amazon, I decide what I want. I decide which product I want, and I decide what I'm going to pay for it in a way, right? Because I can look at several different options, and then I buy it. However, for patients and in healthcare, it's a little reversed. Physicians and healthcare teams make the decisions. So they take your data, they're analyzing it, they're deciding what the treatment plan is, and we'll talk about 4 Ps in a little bit, but where do you then partner with your patients? And I think that co-ownership is what it's going to take, along with data-driven strategies to make sure that we're able to sustain healthcare.
But those consumer-based efforts, just like you're talking about with Amazon, CVS, Walgreens, Boots, they know how to engage and they know how to keep. Let's just look at Amazon buying One Medical for $4 billion. One Medical has neighborhood, places. In fact, on Sharon Heights, for those that are around this area, they replaced my favorite liquor store with a One Medical. I have a picture of it because I give the CEO, I rib him a little bit, Amir Dan Rubin. But I'm getting the opportunity to work with the marketplace that they're putting together at Amazon. Look, they deliver drugs. They have food as medicine at Whole Food. I guarantee you they know where you are. If I have, my whatever, sore throat treated at UCSF and I go to Boston and have an appendectomy, nobody knows anything. But Amazon and some of those other folks know how to put girdles, if you will, around people with their data, irregardless of where you are and where you get it. And that, I think, is an important component. As you say, think about patients, people, as consumers.
But think of it again, that what you're describing is your data owned by somebody else.
True.
It's not you.
True.
If you said that you had your sore throat treated at UCSF, you went to Boston, got your appendectomy, and you own that data and you could bring it to your next healthcare provider, that's where we need to be.
You actually can through the G codes. It's just a pain in the ass. And nobody does it. In Israel, where I spend a fair amount of time, everybody in Israel has it on their phone. All their kids' data, and when they go to place, just basically download it at that given hospital. Now, Israel is a small place, right? But still, we don't have that process easy like we do to order shampoo. And I guarantee you, when Amazon knows you need shampoo once, well, for you, it's like once every 2 weeks because you have beautiful long hair. For me, that doesn't have much hair, it's like once every 6 months. But if they deliver the Lasix at your doorstep at the same time, you know you're going to take your Lasix more often than going to CVS and filling it. So anyway, those folks know continuity.
So continuity and data ownership are something that we debated a little bit when we were talking and getting to know one another. I'm just going to ask a question, like how many of you think out there that the consumer owning their own data is what's going to solve a lot of these challenges? Interesting. Now, think about Dr. Guller's example. There's no other industry in which you own your own data, right? However, and what would that even mean? I would urge folks to think about what would that even mean. But let's take the Amazon example or the Google example where, they announced today, I think is National Password Day or whatever, and they're going to kill the password. And essentially what they're doing is they're focusing on identity. Not data, but identity continuity. And I think that's a lot of what we talked about, which is owning the data itself isn't necessarily the challenge here. It's bringing it together around an identity that can then be used to guide some of the experiences that you've both talked about. So, what's interesting then is like who facilitates that? Who facilitates that identity in the rest of the world, the real world? It's the Googles and the Apple IDs and the Metas of the world, in many cases, unfortunately, right? Who do you think facilitates that in healthcare? Is it like the Karen Alliance? Is it something else?
There's got to be a business model associated with it if it's going to get adopted. Just having an altruistic way of connecting data so that it provides a robust contribution to continuity of care is great, but there's got to be a business model behind it, sorry to say. When I was a young doctor, I didn't like to talk about dollars and patients in the same sentence. Now I talk about dollars before I talk about patients. Because if there's a business model, it gets integrated into the healthcare system. So I would say we need to look for or adopt other business models, and that's why I use Amazon as an example, because they may do it free. Because that connectivity, that consumer focus is really important. And I think that might be at least something we should think about.
And that's an interesting point, right? The business model doesn't necessarily have to be in the individual transaction. It can be connected to other things. Speaking of connectivity and just sort of like these bigger models coming together, what do you think is necessary in order to build on the progress that's been made so far? So, we've got the 21st Century Cures Act, we've got TEFCA, we've got information blocking regs that are trying to set that framework for how do we actually get to some data sharing so that we have continuity around an individual. What do you think what else is necessary, Dr. Guller?
So think about TEFCA for a minute, right? So the three key goals for TEFCA were interoperability, secure, and then patient-centric, right? Those are the three key elements that you need to accomplish. What have we done so far? So how many of you, when you go into your doctor's office, know that there is an electronic health record, right? How many of you, by show of hands? And do you know which one it is? Is it Epic, show of hands? Is it Meditech, Cerner, McKesson? It goes on, right? So what we've done beautifully and successfully is we've created silos of databases which don't connect. Like if you went to UCSF or went to Boston, there's no way of connecting it unless you were on an Epic platform, which you can't guarantee, right? If you had an appendectomy because you had an episode of appendicitis, you didn't know you had to go into a facility that had Epic. So how do you manage that? And I think that that's where we're going to have to ensure that it's going to come by a very concentrated effort, both on the parts of the patients and the providers, to ensure that that stickiness and that glue is there for it to happen. What do you think, Peter?
So who understands what TEFCA is? Yeah, exactly. Oh, you do, okay. You want to stand up and tell us about it? So this is one of those 5 letters, the acronym. It's trusted, what is it? Enterprise? I can't even remember. Well, it's cut up into 2 because the CA at the end is a common contract of some sort, okay? And this was put together by HIT, which was put together by ONC. This is the government now. Remember, 3 acronyms, 4 acronyms, or 5 acronyms. They can't think of anything else, okay? What's that? It's a trickle-down effect, right? And oh yeah, my favorite one is QIMS, which is Quality Health Information Network Service that you have to sign up for if you're a healthcare provider through something called RCE, which is a recognized coordination entity. So this is what we do internally. You know, the CARES Act was 2016, and that's when it was signed, right? And all these acronyms and processes that put the onus on the medical centers. That's not how you solve it. It's like a bucket of water without a hose and you're trying to put the fire out. That's not how you solve this issue, folks. So I love the fact that we have all these things, but nobody's implementing them. I mean, I think TEFCA was 2022 or 21. I mean, you know, so we don't have a lot of experience with this, but again, I'll predict that 5 years from now, these are going to be minimally effective in being able to coordinate, concatenate, and draw conclusions from all these silos, all of a sudden waking up and say, yeah, we'll share. Because there's not an underlying process that's going to force them to do it. In 2021, there were 38 million hospitalizations in the United States. There were 41 million data records stolen. So that's what they stand behind. That's why they're in silos. Nobody wants to get their name in a paper because people, consumers, are what make up hospitals' business, if you will. So I think we're going upstream here. And I just don't think these sort of organizations are going to make that big a difference. I would agree with Dr. Guller, you've got to control your own data. So maybe the Amazons of the world, or maybe the Googles of the world, or look at Microsoft with Nuance, maybe they can give us applications to be able to much more easily get our coordinated data on the edge, the cell phone or your computer.
So we've talked a lot about where we're failing or where there may be existing challenges or the kind of ongoing games of chicken that we're playing with our respective corpuses of data. Where do you think there's actually pockets of success or where we are actually seeing results? Where do you think we can actually continue in the near term to make progress around real use cases? Or, you know, we talked a little bit about the 4 Ps. If you want to bring that in, if you guys want to talk about that. But Dr. Guller, why don't we go to you first?
Sure. So when you talk about 4 Ps, like I mentioned before, you've really got to make it patient-centric. That it really, when you talk about personalized care, let's take that word out of the mix and call it patient-centric. You have to look at outcomes. So you owe it to your patients to have high-quality, safe care, right? As soon as we pivot to that, then we know that all this data that we're getting, we can use it for good, and we don't always have to say, okay, the barrier is, if you look at data today, for example, I can share from just my own personal experience. Within HCA, we have petabytes of data, right? So we're very proud of that. It's what I understand is it's data that could take you from here to the furthest planet in our solar system and back. Okay, just to give perspective. I'm a physician. That's how I relate to data. But when you take that data and then focus on outcomes, we have a tool which is called SPOT, and it's sepsis prediction and optimization of therapy. Again, acronyms, right? We love those. What it does is it alerts the healthcare providers, the physicians and nurses at bedside, to say, hey, the patient's heart rate is up, the patient's blood pressure is low. Even one of the 4 elements that really determines sepsis, and sepsis is bloodstream infection. So your infection that was probably in your finger, spread up your arm, is now in your entire body by virtue of being in your bloodstream. It alerts to immediate action, which is then providing fluids, antibiotics, taking care of the patient to ensure that they don't get sicker while on your watch. And the way it translates is it gets the patient better, it reduces morbidity, and it has impacted and improved mortality. So that means one more dad who was able to walk his daughter down the aisle, one more grandma who was able to go back and attend her grandson's graduation. So that's how we look at data on the healthcare side, and that's the outcomes that we hope for. When you bring in AI and generative AI and things like that, how are we going to do more with less? And that's your documentation. So think about giving an AI platform just a few key bits of data that your patient shared with you, and it's able to generate a whole entire note, a clinical note, by the way. And I've done it myself, just looked at it just by terms of playing, not really in healthcare because we're not ready for that. But just as I'm playing with it, the vignette is beautiful. It really gives you in-depth information. It's a robust documentation of your patient care. And I'm looking forward to more of that because what it allows the patients, caregivers, both nurses and physicians, to do is step away from the computer for a minute, make eye contact, and actually take care of you. So that's where we need to head.
I want you as my doctor.
I'll be honored.
I'd be a pain in the ass. No, you're great because you really get down, and the 4 Ps, just so everybody understands, it's payers, providers, physicians, and most importantly, the patients, okay? Just so everybody has that lingo down. And I think that having that sort of, biomarker, let's say, in a smart bed is going to now, what she's dealing with in the hospital can be taken home. So if you don't think hospitals at home are going to be one of the next big things, you're wrong. And these sensors that we have, whether it's on our wrist, whether it's a patch on your chest, whether it's a sensor in your bed, there are ways to take that with potentially less skilled folks that can go visit. That's going to be how hospital at home is going to take place, and it's going to take place in a huge way. And I would, further say that Providence, your hospital system, can now begin to coalesce that data, even if it's only in your organization, and get better at the next 75-year-old that you're going to provide care for that has pneumonia at home. And I think that's the analytic component that's going to help maybe just in your area. And if they do go to Boston and have an appendectomy, well, we're not going to get there for a while, but we can get in our own communities. And I look forward to Providence, Intermountain Health, and some of their organizations, some of these HMOs being able to use their own data for how they are servicing their outlying communities. But I think sensors are a really important issue. You're seeing now chronic neurologic diseases working with Apple Watches so that you can begin to track whether my mother has a probability of falling in the next 2 months, whether their Parkinson's disease is getting worse, because the worst thing we do with Parkinson's disease is they come in and they say, I'm doing fine. And we have no idea how much dopamine we're giving them, dopaminergic drugs. So being able to detect maybe Parkinson's or even other dementia type processes way back on the curve is going to give us far more ability to bend the curve from there than to bend it when it's apparent to us doctors. So I think that there are a whole bunch of examples, and I'll just leave one by saying this consumerized healthcare is going to take over. And who is the most dominant consumer in the world? Women. 70 to 80% of purchases and influences is done by women. And maybe this will actually help women's health, which has been a real tragedy of how things have been addressed going forward. And I look forward to some of those Amazons and Googles getting involved, because they're going to think about the consumer, and the woman is going to be much more impactful in those healthcare journeys.
You both kind of touched on this, but there are certain frameworks that are in place where we can build on them. For instance, open ID standards, which are starting to get some adoption. And those open ID standards, even if they're deployed within a given organization, can start to create connectivity across at least, let's say, digital point solutions, so that we can provide a much more sort of whole person oriented care, even if within like Providence's footprint or HCA's footprint. So, you know, for folks out there, if you haven't started to think about OpenID and deploying OpenID, that is a very important first step. And the one other thing I'll say is that there are certain electronic medical records who technically comply with OpenID, but have not implemented them in standard ways, which makes it much more difficult. So being sophisticated about how we think about OpenID and then deploying it across our own systems is a good starting point.
No, I'm dying to ask you some of the answers to these, because you run a huge system. And being able to do that continuity of care, whether they're in the northern part of your district or the southern part of your district, that's a big deal. So
yes.
Where do you see, you know, the enthusiasm, if you will, for some of the data, some of the sensors, some of those processes that we're getting better at for being more standardized and doing the same thing for a guy that's got prostate cancer in Seattle as you would in Ashland, Oregon? I mean, what do you see as those?
Well, so clinical practice standardization is a whole other issue for us. But where we've started is with identity. And that was a very difficult challenge for us. But today, we have 4 million patients on an identity platform that is completely synchronized across our entire network, and it's not dependent on the clinical record to be synchronized. So it sits outside of the clinical record, and it allows for SAML integrations and handshakes with external partners. It allows for single sign-on. It provides that level of continuity for a given individual, so that, you know, we can see everything regardless of whether they went in Puget Sound in the Seattle area or whether they went in Southern California. So that's where we've started, and it's 4 million people that come into our community. So that's where, you know, that was an important starting point for us.
And that's where we should start. Solving the problem of my appendectomy in Boston, forget it. That's too big a chunk right now. Let's solve it at your hospitals and your outreach programs and hers, and that's where we're going to learn from what the right way to do it, maybe nationally is, but that's going to take a while to get there.
All right, well, we're getting the hook. So I'm going to wrap us up with one final thought from each of you. What is one really important takeaway, one really important sentence, let's keep it to one sentence, that you would urge payers, providers, technology partners, any stakeholder to be doing around data sharing and interoperability to advance the quadruple aim?
So do more of what you're doing. Show up, be here, listen in, pay attention. That's what I would say. This is what's going to take us to the next level.
For those that are healthcare folks in this room, myself and Dr. Guller, be open to new technologies. Work with folks that have experiences in other verticals that can solve some of these. They're not science projects. They're not that big a problem. We've just made them problematic in healthcare. Open the door to those folks, and I guarantee you in 3 to 4 years we're going to be in a much better place, and maybe that $4 trillion that we spent today is not going to get to what was predicted to be 9. And it will be more efficient, and ultimately treat patients, people, consumers better.
And I will say, don't leave your patient and consumer relationships exclusively up to the electronic medical record. Thank you.